So next up, we're going to have our question and answer panel. So as you see, we have a number of people in the audience that are obviously already very experienced doing injections, as well as our panelists. We've got Dr. Nguyen, one of our orthopedic surgeons that's very helpful with teaching in the program. Andy Jones, who teaches our MSK ultrasound, as does Ryan Erdley for our residents. We've got Dr. Bob Bleakney, head of MSK Radiology here, and Dr. Michael Catapano, a Sunnybrook physiatrist who has not only experience here, but also having done fellowship down the States. So some interesting perspectives. So I've given them some questions that have come up already over the last 6 months through our Greater Toronto Area WhatsApp group, but any questions you have so far, now that we've gone through a number of different points about injections, by all means. So guys, if you want to come on up.
Can you bring your chairs too?
Yeah.
That's all the chairs I got. Michael, I have a chair. Yeah. No more chairs. Actually, yeah, can I roll that one out? Thank you.
Do you guys want to come over actually this side, go closer?
Yeah,
Just
live stream over there. All the way over?
yeah, bring them all the way over on this side here. Okay, anybody have any questions to start? So let me ask you guys to start off a question. We already did a talk today about side effects and adverse events with musculoskeletal injections. What have you guys encountered or experienced in terms of like adverse events, apart from what we classically describe to patients in terms of infection and failure and stuff?
Should we close the door?
Not in your case.
We do a lot of our injections under fluoroscopy, particularly joints. So we do a fair amount of the soft tissue stuff under ultrasound. I remember I was supervising a resident once, and the tech called, and it's always bad when the tech calls, would you like to come in? And they were injecting the contrast, and I was like, I had no idea where they were. And they'd actually put the needle through the patient into the bed, and we're injecting it into the foam behind the patient, which was why it was like so unusual looking. So I would say like that inadvertent injection of other areas. So.
Did the foam get better?
Yeah. Well, our whole thing then was like, well, what do we do with this needle? Do we just like, because it's the same bed that we use for burying animals. And I was thinking like, do we just take it out to give it some antibiotics, or do we try and, we had this discussion, should we cut it at the top and then pull it out through the other direction? So we just pulled it out.
What
And
bite is that?
a shoulder, just like a little old lady. Yeah. And put it like straight through into the bed behind him.
Still alive?
Yes, he's still alive.
Yeah, I would say like the most common one I've seen that I didn't expect is a lot of young females come in and tell me that menstrual cycles are off, which I never always thought of. But using higher doses, like, I find 40 of Kenalog or 80 of Depo, they'll come in and say like, my menstrual period was late or early and whatnot. And usually it's like an urgent phone call, like, because they're worried about other things, pregnancy and whatnot. So that's something I always tell young females now, because like a couple times I've been caught.
I'd say also postmenopausal females. I know
Yeah.
got a Tarzan shot, she started having spotting, so she thought she had endometrial cancer.
Yeah.
And so she was pretty pissed about that.
Yeah. It's surprising how upset they get. And I mean, I don't do any of that part of the body, so I'm usually useless.
I think the most common complication you'll see is the flare-up of pain that was mentioned earlier. So you have to preempt the patient. I usually ice the shoulder or knee for 2 days, and then I'm taught to behave for about a week, and then maximally at 6 weeks for the HL, either HA or combined PRP, and it starts to work usually at that time. So, and especially in the sports population, they want to go back and play right away or exercise right away. So it kind of defeats the purpose of doing injection if they exercise right away.
Like I would say, from my perspective, the two injections that we do, that probably the patients have the biggest sort of flare up, would be when we do barbotage in the shoulder for calcific tendinopathy. So they'll often have like a lot of rebound pain. And also, they were talking about plantar fascia. For some reason, like the plantar fascia injections can be really, really painful for the patients. The other one that you guys probably will not do as much, but like a symphysis pubis injection. Again, like there's not a lot of a joint space there, so it can be really quite difficult to get a lot of fluid into it. And that can be really an unpleasant procedure for the patient and the doctor. It's not a particularly pleasant injection, but definitely barbotage and plantar fasciitis are just two that are more commonly done that are, unusually painful for the patient the next day sometimes.
Yeah, and for the barbotage, I try to do a cortisone, like a subacromial
Yeah,
subdeltoid cortisone
yeah.
for them, but tell them it's going to be worse. And we've always had the teaching like hydrodilatations for frozen shoulders. They can sometimes get some rebound pain as well from it. So I usually tell people like, give it a bit before it's better. It's going to be worse before it's better. Similar like a surgical intervention, like there's pain up front for long-term sort of improvement.
Yeah.
So like any of those, I tend to find that they get more painful.
Like there's that gap between sort of when the local anesthetic wears off and the steroid kicks in. And I think then they become really worried that it hasn't worked and this sort of thing. So as long as you explain to them that it's going to get better tomorrow, and it may have a rebound to start with.
The ones that I've had that were unusual with HA in particular, one was a knee that one of my residents was doing with me. And they did a great job. They got right to the right spot. But the patient didn't have a Baker cyst the day before. And 2 days later, she came back with a big Baker's. We said, oh, well, it's probably just the HA. And then she ruptured the Baker's. So she ended up HA all through her calf. And that was particularly painful for her. It wasn't something I thought about before. Another one, similar kind of thing, glenohumeral injection of HA. She had bad osteoarthritis and was kind of crummy anyways, but then she said, all of a sudden, doc, when I get to here, it really, really hurts me. And we put the ultrasound on a couple of days later, and all that HA was sitting in this supraspinatus bursa. So
Yeah.
she just had moved around.
HA can cause a big flare-up, so that's why I added cortisone like a few years back, and then I added infused with PRP to kind of preempt that flare-up. So it doesn't matter where you inject it, in the bursa, the joint, or the shoulder, or any kind of small space, it will cause a flare-up.
How much do you put in with your HA? Like 20 to 40, or do you use a full dose?
Yeah, for those. If the AC joint, then I inject less, same as symphysis pubis. There's not a lot of space to go in. And then I usually bathe around the lateral condyle or the tendons, but I inject the whole thing. I preempt with cortisone or PRP. I do PRP more nowadays than cortisone. I changed the practice due to all the flare-ups.
Right.
I just haven't, like, I find I do a lot of HA in young patients with OA, like that's what I get from sort of like Sunnybrook colleagues. There's a lot of it is like early OA that aren't a candidate for salvage procedures or whatnot. So I'll just do the HA for them, and then I'll tell them if they come back with a flare, like call me early, and then I'll do the steroid, just so that I can avoid steroid and avoid the cost of like PRP and whatnot.
You can speak a little bit on PRP flares and what you experienced with that.
Yeah, I mean, when I in fellowship did a ton of PRP for tendons and joints, I find that the joints, as long as I'm using a leukocyte pour protocol, like I don't find they flare that much. I typically do a 1 injection protocol, so I don't have them come back. I find like the second and third, like, the research or the studies are like an injection after 2 weeks or 3 weeks for either a 2 or 3 cycle. I find that's when they start to become more flared, maybe because of volume, maybe because I traumatize the exact same area twice in a short period of time. So I just do 1 injection for joints, and I find that they do well. And like I've only been in practice for a short period of time, but my fellowship preceptors say they do well. So I just do a 1, and I don't find they flare as much. The tendon procedures, I do like a limited fenestration, so I find that they don't flare quite as well. Like there was always, like, from what I've seen, the 2 groups, sort of like 2 or 3 sets of fenestrations with like leukocyte-rich PRP. And then there's a group, like the Emory group, and all those people who do like 20 or 30 fenestrations, or like they'll describe in some papers like fenestrating the tendon until there's no more resistance to it. I find those people are really flared. And, I've been described like both ways I find people do just as well. So I do a very like limited fenestration with a lot of peri-tendon injection, especially in young people, because I don't find they flare quite as much. And they're not as upset. Like the people who really flare, I just find they don't do well, and they're really upset at me like up until like 12 weeks. And 12 weeks they're better, but then they're like, I would never do it again anyways. I'm not sure if it was worth it. So I find the limited fenestration, they do a little bit better and they don't get as much flare.
Yeah, PRP is well tolerated, but you have to be careful about injecting hot inflamed joints because they always don't do well. So either you inject cortisone, rehab, physio, let the inflammation settle, then do your fancy HA PRP injections.
And you're waiting about 3 months, are you, after the cortisone?
6 weeks to 3 months,
Yeah.
it depends. But they usually come in painful, swollen, so if you inject anything, it's gonna cause more flare-up.
Can you, either Michael or
That's a question.
I'm sorry.
Go ahead, John.
I'm curious if you guys have a preference in terms of the brand of HA you guys prefer, personally?
I use Durolane.
Yeah, I really like Durolane. I mean, I try to somewhat, like if somebody has a flare, the thought is that the monovisc is much lower molecular weight and it's much more like physiologic in terms of its weight. So if somebody has a flare on Durolane or Synvisc, then I'll use monovisc in the future just because it's lower molecular weight. So it's more slightly more physiologic to the joint. And I do find they flare less, but I find that if I use monovisc in everyone, they don't do as well as the Durolane. And I just find that the Synvisc has more flares just because of the 6 cc's versus the Durolane. So like I'll use Durolane, and if they do flare, I either will tell them like, if you're gonna flare the next time, I'll do it with steroid, or we'll try monovisc to try to avoid steroid use.
Like we will basically inject whenever anyone tells us to. As long as I'm not sort of breaching any ethical laws, that sort of thing. But so like over the years, it has, it's been very varied, but I would say like Synvisc, Orthovisc, Durolane, but I would say now 95% of the HA would be Durolane that people are asking us to inject.
If you go by the literature, then you should inject the highest molecular weight, so that'll be Synvisc. But based on experience, anything goes because the literature is so murky.
You guys have any advice for the young sort of professional athlete with post-traumatic knee OA and still has in his mind or her mind quite a few years left in their career? And what are your suggestions for them?
Bless you.
Stop your sport. I mean, ultimately, like it's hard with them. Again, like I've only been in practice for a short period, but I found that the professional athletes, a lot of them came in dictating what they wanted. So it's like I found that a lot of them come in and say like, my agent or I spoke to this other player. They had this and they did well. And there's some aspects of sports psychology or placebo effect to them, and they want this, and they're like, this is what's going to make me better. And I honestly like the suggestion I've got is like not fight them. Like if they want it and they can afford it, as long as it's not repeated cortisone injections into like vulnerable tendons to do it. So patients usually come in with asking for something. So PRP or asking for a referral for like bone marrow or fat aspirin. And ultimately, if that's what they're interested, I just give them what they wanted, mostly because they already have a pretty strong preconceived notion of what they want. That's what I found.
With the same experience with a lot of soccer players, it's sort of once something becomes very popular in the UK, then it's the same thing. People become sort of like very superstitious, and somebody I know got this and it worked very well, and they're doing sort of adhesiolysis and doing neurolysis for chronic hamstring injuries now that we've been asked to do, and I'm looking at it thinking like I'm not comfortable with a lot of that sort of stuff. So it's difficult at times when they come very much with prescription of this is what I want,
Yeah, I find like some of the professional athletes that we had treated, we try to like for PRP and some of these things, like we tell them is like it's really just for pain management. It's not really to help in health of the joint, but in their mind, they need to get it every 3 months for them to perform. So like they'll come in with a completely quiet joint, no effusion, performing well, but they're like, I need my PRP at 3 months. And like they'll get it in the US on the off season, like wherever they're playing. And then they'll come home and they're like, well, I had it every 3 months there. I need to get it every 3 months here. So I find it, I just, has like, it's not worth fighting them because they'll just end up going to someone else and get it. As long as you're not causing them damage for it, then it's, if it's working for their sports, just do it.
Yeah, pro players don't listen, so just do whatever they want as long as you explain to them, educate, and I usually do HA plus PRP plus unloader, depends on what side the pain is.
One of the things I would say in that particular group, sometimes it's a difficult situation for us because I find myself, I'm guiding an injection that's being done by somebody else. And I think in those instances, you'll find when you're doing ultrasound yourself, like it's very easy when I'm holding the probe and I have the needle to sort of think, well, I have a fair idea of where I am and I want to be perpendicular to the needle. But if I'm trying to find the needle that someone else is introducing, it's very, very difficult. So a lot of times I just wish I could like grab the needle and just say, let me do this myself. But I think it's a particular group of people that, everyone wants to be involved and, give them a good experience.
Yeah. I couldn't imagine that'd be much more difficult for me.
Yeah.
The lack of control.
Going back to Duong's question about the education, how do you educate patients with respect to the mechanism of care? Specifically with joint, like I haven't, I don't know, this is probably simplistic, but like from a tendon, I tell them like we're injecting, like healing factors and basically we're like recreating the acute injury and hoping it heals again. So like that concept makes a little bit of sense to me, but when we're talking about like joint OA, for example, I don't know how to like plug that, but it, like why might it help?
Can you think too much?
I know.
It was said already. He doesn't care what he does. He just helps the patient.
Yeah.
Dr. Placebo.
Yeah.
Dr.
If it
Placebo is
helps,
30% effective.
Because I have people asking me the questions and I have to look like I'm thinking
I just have to say it may. We don't have the evidence.
Is it just that idea that there's some like anti-nociceptive factors? Because I know you said, I say like it's just for pain management.
Yeah, so I tell them it's just for pain management, and what the evidence for the leukocyte poor PRP is that there are still a lot of similar like there is for tendons. There's a lot of chemokines and cytokines. So what I explain to patients, I mean, from a higher level, there's a lot of IL-6 and TNF alpha that is meant to really reset the milieu of the joint, so that's not inflammatory in nature, because ultimately it's not actually causing any healing that we see in terms of repeated MRI. So what I usually tell patients is it's a very expensive anti-inflammatory that's hopefully going to last longer than the steroid. So I tell them it's not really meant to do healing, that there's no good evidence that it's going to do that, but what it's going to do is decrease inflammation, similar to steroid, but not cause any damage to the knee. And that's kind of what they're still looking at, but that is the way it was explained to me, and that's sort of what the evidence is leaning towards. And that's why it's leukocyte poor as well, because the leukocyte rich, it just causes too much inflammation and there's no real healing to happen. So as much as it's still a bit of hand waving, that's where the evidence is leaning towards.
If you look at the meta-analyses, the tennis elbow, plantar fasciitis, and knee arthritis has the most potential positive outcomes. So that's the literature. And then you have to talk about all the interleukins and all that stuff. But at the end of the day, if you inject that in the face to make it beautiful with a band facial, then it's okay to make the knee beautiful.
Yeah.
Never described it like that, but that seems maybe I'll use that one more frequently. Yeah.
If it grows hair, if it grows teeth, it's going to regrow your cartilage. There's a lot of animal studies. You can refer to the animal studies, but we don't have human outcome.
We looked at it at Toronto Western, the people that were getting PRP in the knee with sort of serial MR. And we didn't see that it sort of grew any cartilage in the patients in that subset. They weren't getting any worse like you may see with the corticosteroid. So I think if you're thinking what would be better to give someone long-term into a knee, is it going to be a steroid with the risk of rapidly progressive OA, versus PRP? PRP makes a little bit more sense to me from that perspective in a sort of first do no harm sort of thing.
I do tell patients that, because a lot of patients come in saying, is this going to regrow cartilage? And I usually tell them, in the best case scenario, it might help you save the cartilage, but the evidence is somewhat weak for that. But I was if you really want to hang on to something, I was maybe it helps you save cartilage and doesn't degrade it as fast.
If you read the cartilage repair literature, there's a few studies showing potential HA and PRP helping with faster healing based on imaging, based on histology.
So I think one of the things to further, like, we don't know, but given the fact that a number of injectorates have a similar effect, it may just be delusional, but it may also be that the PRP is blocking some part of the inflammatory pathways. And so in terms of just adding theories to why it may be working in a joint. Can you guys comment maybe on, do you do any radiofrequency ablation?
I
For like either sports hernia, knee arthritis, even hip arthritis?
Yeah.
Refer people, I need your card before we leave here.
Oh, yeah. Well, I mean, hopefully not too many because I don't have so much RFA time, but I do it for hips and knees and sometimes shoulders. I don't know if you guys do.
We do it for like a bone tumors. So like there's
Yeah.
a particular osteoma that we would do. I see a lot of our fluoroscopy is being used by the pain service, so anesthesia, physiatry as well. And so there's people doing a lot of RFA. I must say more spinal work I see in around sort of like facet joints. But we are seeing that. One of our previous fellows is doing RFA now even for mortgage neuroma. So like I think it's, you know, it's really branching out into lots of different areas, but we haven't gone into the sort of soft tissues as yet.
Yeah, so I'll do it for mortise, I'll do it for mortise neuroma, for spine. But really the way I've done it is just taken like what I did in spine and just apply the exact same settings, but for the hips, and obviously in a different location, but same RFA settings just in the hip and knee. The problem I find with the knee is the lesion for a medial branch is relatively small. So I do a very small like strip lesion, or I just kind of like, if you look at an RF needle, it's bent 30 degrees at the end. So when you turn it, it's 180 like it'll move significantly in the soft tissues. So for a medial branch, I just turn it and it gets a relatively large enough needle or a large enough lesion where I think it hits the nerve because it's a very small space. The problem with the knee is that same needle, which the needles are quite expensive for it, just the basic needles, you pretty much have to like drag it along the femur to get a large enough lesion to hopefully hit the genicular nerves. And I just do a 3, like I just do superior lateral, superior medial, and inferior medial, right? But the problem is that I'd like to get just one spot in a lesion that's large enough, but instead I pretty much drag it along to try to save the money from the actual needles, because the ideal and a lot of what is happening in the US is the genicular nerve RFA is on cooled radiofrequency RFA. So pretty much what larger needle, but also it has a fluid that cools through it. So it actually cools the outside of the lesion where the inside is hot. So you have actually a more defined lesion. Whereas the regular RFA needles, the energy just gets hot at the tip. So the energy disperses out. So you get like a nice lesion in the center, but then you get like kind of like weird charring out as you get out. Yeah, and I find patients get a little bit of pain from it, and some of like my preceptors would inject steroid after they did the RFA to decrease some of the healing, to decrease the healing so that it lasts longer, and also decrease some of the irritation. But what I find for the knee is I get variable results. What I'm doing it mostly for, to be honest, because I'm at Sunnybrook, is post total knee replacement pain. So it's somewhat a little bit easier because I know that they don't have any other option anyway, so I'll just try it and see. And they've already been like evaluated for other issues. I find that I don't get as good results as I did with like other injections. Like 50% of pain relief is like more than positive for me. Like 50%, I was like, patients will come in and they're like, my pain's 50% better. It didn't work, and I was like, no, in my mind that's like perfect. I was like, see me again like when it comes back to 100%. Whereas like more the cortisone, I'm hoping for higher, or like other injections hoping for a higher pain relief. Yeah.
And have you tried injecting N-Stride? And can you speak to any experiences, patient outcomes?
I can tell. Does anybody use N-Stride? So I don't use N-Stride for the sole reason of it's more expensive and it just doesn't make like much biologic sense to me. Again, N-Stride's not available in the US. It's not an option there for them. But when I've spoken to some of like the biologic conferences and stuff, most of them wouldn't use it, and that's why they haven't come to there. So I don't use it just because it's more expensive, and there's just no good evidence that's any better.
I haven't because of similar reasons. Also, Lucas at 4 versus Lucas Elrich. So I inject a lot of knees and joints, so I haven't tried that yet. A lot of patients have mentioned it, so I just referred to somewhere else.
Dr. Jones, when you inject saline,
yeah.
what's the talk you give to patients? Like, how do you sort of describe it? Because if it's a placebo, are you negating the placebo effect by telling them that,
That's a good question.
right? So how do you kind of approach that conversation?
Yeah, no, that's an awesome question. I tell them that they come in to me with pain and they want to leave without pain. And so I say, this is what you've tried, right? Shanice can tell you because she's heard me have this talk 1,000 times in my office. This is what you've tried and this stuff hasn't worked. This is what's available but you can't afford. And this is what you're completely and utterly unwilling to do for yourself. And if that continues, then our options are limited. But an option would be, and there's a study that shows us that, putting in a few cc's of saline into your knee may be useful to you. It's not going to hurt you, 1 in 10,000, 1 in 30,000 risk factor for infection, et cetera, et cetera, et cetera. And so they approach it as being positive from the beginning because it's something to be done that they don't have to do themselves. And I find that that's helpful.
Do you do a special dance too, or?
I don't dance. I don't dance. I should dance.
Some music on.
As much as it'll take. I'll drop 20 cc's and see when it starts to push back. Yeah.
There was, I'm going to quote from an article. It's a great article in the Society of Skeletal Radiology Journal, and it's basically the use of the placebo effect in MSK. And one of the things that they talk about at the end, which are like here, I think that's a positive, confident attitude of both clinician and patient to treatment can increase efficacy. Stating reassurance such that the treatment provides relief to the majority of patients has been shown to produce positive results. And then this is always I find difficult with giving informed consent, because it's saying here, providing overly worrisome information to a patient when obtaining consent is less advisable, particularly in the setting of significant pre-procedural anxiety. So patient experience and treatment efficacy can improve if the patient is given control over some aspect of the procedure. Even talks about some articles where the patient is given a choice of music they can listen to through the procedure. And the patients that had a choice in some aspect of their treatment did better than the people that didn't have a choice. So I think I'm always like, that went really, really well. Exactly in the right place. That's exactly where we wanted to be. So I think it's something that you can certainly use to your advantage going forward as well. I think particularly using image guidance is great for you guys to say, and even at times show them the needle, because it's a very visual sort of thing that I find, like, here's the scan, there's the needle, it's going exactly where it needs to go.
Patients love it.
Yeah.
They love ultrasound guided injections.
So Andy, you need to not only say yes, but let your patients choose the music.
Oh,
Yeah.
He said don't do anything terribly worse or upsetting.
No, it works also in surgery. I let them choose the song before they go to sleep. And that choice, that control, because they feel like helpless as a patient, right? They're like in a gown, it's cold. So the choice and control and explaining. And then you can talk about pros and cons of cytokines at the initial visit, but at the intervention day, it's all positive. It's going to be a great day. We're going to win this game.
Even like some of our procedures like vertebroplasty, for instance, there's been shown like a sham procedure where they're in a room, the needles are put down onto the pedicles, they've mixed up the cement in the room so the patient can smell the cement, but they don't actually get the vertebroplasty. There's no difference between the procedure and a sham procedure, no significant difference. So a couple of really big studies in the New England Journal of Medicine have shown that. So I think there is this aspect, even the smell in the room can impact it as well.
Being more comfortable with the material, the literature, your procedure, the more comfortable you are with that, the more time you can spend on the art of what you're saying, what words you're choosing. And that comes with time with all of us, but we always have opportunities to improve and make that more efficient. And ultimately, I agree with all that. I think there is an effect of what I say and how I say it to people. It doesn't hurt to try and continually reevaluate that in ourselves to figure out sort of how we do things better.
My husband tells me I spend far too much time trying to talk people out of things that make us money. That is true.
I'm curious for therapy for tendons or plantar fascia, let's say you see a functional tear.
do you guys normally routinely do a repeat scan after this to check for healing, or do you just focus on clinical status? A lot of patients want to get something to recheck it. And kind of along the lines of that, it's a joint injection. A lot of patients be like, well, should we rescan this and see if the meniscus, see if cartilage is better? I'm curious how you guys handle those.
You know, like I would always sort of be very wary of that. Like I know our imaging findings can be there for a long, long time and far outstrip the sort of clinical benefit the patient has got. I really see that particularly in Achilles. You know, if someone's had a previous Achilles tear or previous repair, it'll look like a dog's breakfast for the rest of their life. And so I think if they're expecting it to go back to a normal Achilles, that's never going to happen. So I know even in a lot of the athletes, they're looking for another scan for return to play, and say like there's still going to be edema here. We're still going to see a lot of abnormalities. So I don't know how it's going to really make a difference. You should probably go more on clinical. So, like having said that, you can do the scan, yourself. You can make an ultrasound look like anything to me. So it's like it's no worse.
Yeah.
Maybe the area of partial tearing is healed in a bit, but it's still going to be thickened and heterogeneous for sure.
I put the ultrasound scan machine on the patient's area of interest, and I say, that looks better to me.
Yeah.
Yeah. I'd say the only ones I rescan are I find that a lot of the lateral epicondyles, they have a partial tear that I can actually get into ERP, and same with the plantar fascia. So those ones I'll rescan at like 3 months, because that's when I tell them when their healing is. And I find that they are sometimes like they've adhered. Those are the only ones I will rescan. Like joints, I tell them there's no point, because I tell them it's really for pain management. So it's going to look the same.
That's the beauty of the ultrasound. Like was said earlier, you can make it tear heal in 1 second by just shifting your wrist. And the patients love that, and patients want that. For joints, it's less useful, and then it's all about patient education. You do the injection for pain, not for healing.
Why do you think there's a disparity between, like Ross, you mentioned the guidelines? Why the guidelines don't seem to support PRP, for example, or even HA in some cases? What I mean, it's multifactorial, but let's go through the list of what you think those guidelines aren't picking up some of these newer.
You're talking about the ORC guidelines?
Say again?
Talking about the ORC guidelines, 2019?
You could name any.
Yeah, the
number of
ACR also
guidelines
doesn't
that are
take it.
not on the list.
I mean, it's already, I think, spoken about. I think there's a lot of variability between HA products and PRP products in terms of who injects with without guidance. And then it depends on the outcome measures. And then you have to actually group them together and then have a long-term outcome. So I think at the end of the day, I mean, so far what we know is like HA may work with a higher molecular weight. And then in sick patients from the ORC guidelines, then actually goes up to like a level 2 recommendation if you have other comorbidities you can't take oral NSAIDs. And then you just have to tell the patient that. And then at the end of the day, you don't know until you have better outcomes. And PRP for the knee, the plantar fascia, and the elbow shows some positive leaning towards good outcomes, but it's not guaranteed. So if they've tried everything else, saline and dance and music, and then they want to try something that's that they can maybe try the injection.
I think it's as you say, it's such a heterogeneous group of interventions. Like we had like the Ontario Association of Radiologists meeting where we invited someone that does a lot of PRP to speak about it. And they wouldn't actually tell us what they did. It was almost like what they did was special and a secret. And there is a bit of that associated with it. The same coming down to a lot of those articles you were talking about that wouldn't actually say exactly what they did. And so I think maybe it's like a business decision they're trying to make. I don't know, but I find it frustrating sometimes how difficult it is to get the information about exactly what has been done, what they're doing, how often they're injecting it, where they're injecting it at times.
Yeah, I would agree. I think personally, the overarching thing is like, I don't know if there's truly enough evidence to say with 100% certainty it works. So part of the reason we not made the guidelines is because it may come out 10 or 15 years from now and not have actually provided significant benefit over placebo. I think like part of what the pain literature, and I think, although this is like a musculoskeletal condition, like we treated a lot of its pain to it. And a lot of the pain literature is moving away from just grouping everybody into their outcomes and going by means of it, because, I think similar to pain injections, similar to PRP and these injections, you have and I tell people there's responders and non-responders for these. So what I typically would say is if it works, which I usually tell people 50% of people, just because to undersell, some of the data may say up to 2/3 of people respond. The people who respond have good outcomes, but the people who don't respond have no improvement. It's not like a mediocre improvement in everyone. If people have good outcomes, people have bad outcomes. If you combine them, you have a small signal. So a lot of the research is going to sort of dichotomizing people into people who meet the minimally clinically important difference in one group versus the number that meet it in the other group. That may make a difference, and we're seeing that for some of the pain interventions that previously were negative in randomized controlled trials, but people always said that they work. So I think PRP may end up that way as well, but part of the overarching thing is, we're not 100% sure it works.
Can I give you notice any, I don't know if I would call it patient selection factor, but sometimes, someone has failed a bunch of stuff. They didn't get better from the steroid, they didn't get better from the HA. You find that patient is less likely to then have an improvement with the next thing on the list. And does that affect how you choose your list? The example I'm thinking of are several patients who have tried maybe 5 N-strides, over 5, couple of PRPs, didn't have any good outcome. And I'm wondering is that because I chose the patients that weren't getting better with anything and hey, let's try this last thing that I have on the list? Or is that why I'm having some sort of bias about no outcomes? Or are those things just not working? And are you finding any kind of individual differences between patients like that?
There are 5 N-strides.
I've 5 in my 6-year career.
Total, not in the same patient. Total N-stride. I was like, that's a lot of N-stride. I was like, a lot of meat. Yeah. Yeah. Yeah, I think patient selections are big. Paul Marks at Sunnybrook has always said, whenever you've worked with them, patient selection is the number one thing for good outcomes, or if you pick a good patient. But ultimately, you don't get a ton of choice. You don't get a ton of choice if who comes through the door. So yeah, I'm 100%. If somebody's tried a bunch of things in the past and it hasn't worked, I usually am not as confident to say yeah, let's give this a try. Just because if they've been a non-responder, there's such a large psychogenic component of pain as well and whatnot. They haven't responded to anything in the past. I'm pretty hesitant to want to push the envelope on that particular patient if they've had even no response. I try to even go back to their local anesthetic response. So I'll go back to them and be well, were you better for at least the first 4 to 6 hours, right? And I'll do a basic cortisone injection and really monitor them myself for the first 15 minutes. And if they're not better with even that, then I say, I don't think any of these are really going to help you. Maybe we look at a multidisciplinary pain, attack it from a different aspect, and that's when I usually send them on to someone else.
I think the local anesthetic there is a great point, and more so now around hips. A lot of times you're just asked to inject anesthetic into the joint to see if it's going to help the patient. So it's more of a diagnostic test than a therapeutic procedure for the orthopedic surgeon. So I think local anesthetic should have some impact, and if they're not getting that sort of few hours to start with, or a lot of times with our spine stuff, the patient will come off the table and it'll be I'm better, I feel great. So from that perspective, it's a great feedback for us to get, and then we can say we're in exactly the right place. That's good, but then it's a matter of how long it's going to last.
I think if you select the patient well, then you always have a good outcome. Maybe if you're too picky, then you never practice. But that patient sounds like a more challenging patient if they haven't responded to all these injections. So either you miss the diagnosis or it's a DSM-5 psych patient, and then it's a pain patient.
This might be just my take on this too when it comes to the community, but in my practice, I see a lot of people who have been told they have osteoarthritis, and they do, but some have a much more inflammatory type of osteoarthritis than others that are more degenerative. And I find that they respond differently. So if you have a more degenerative kind, they're not really inflamed all the time, cortisone doesn't do much for those guys. Got a more inflamed guy, he's going to do a little bit better with cortisone, maybe not quite so well as something that's going to be irritant, like a HA. So I try to, in terms of my patient selection, that's how I counsel them through that.
We see that a lot on our imaging as well. We'll see some people who have really bad OA, but what looks like a relatively dry knee. And then we'll see some with effusion and synovitis and osteochondral debris. And then sometimes they'll get referred to a rheumatologist. And I'm like, no, this is not like a primary inflammatory arthritis. This is just secondary to their degenerative changes. And you can see that those people could maybe benefit from an intervention.
Yeah, I agree. Like I sometimes will see patients with OA and knee OA, and I'm like, oh, this is going to be such an easy ultrasound procedure because like for sure we'll have an effusion. And I put the ultrasound on, and I'm like struggling to find any any fluid in it. So I agree. Sometimes you'll get patients who have like crazy fluid, but you'll get like dry knees with OA and pain. I still do the cortisone.
There you go.
I still do it, but I do agree.
Time for one last question, then we got lunch. Yeah.
I had a question with regards to, I know some of the chronic pain guidelines have changed, like CPSO is now requiring you guys to save images and that kind of stuff. I'm curious if you guys think this might come towards kind of like, are they going to start requiring injections to be ultrasound guided or to save the images? I'm curious what your thoughts are on that, especially when I think we do it. So what are your thoughts on this new change?
So it's interesting, like firstly, like there's, because I do a bit in and out of hospital, like the in-hospital guidelines are completely different than the out-of-hospital guidelines, right? So like, it came out more like the neuroaxial blocks, which is kind of like vague. So obviously like spine is for sure in that you need to save your images, but suprascapular nerve blocks, tibial nerve blocks, these things that are appendicular, it's unclear if you truly have to save it. But I can tell you that I would foresee it coming because in the US, it's already like that. So whenever I did an intervention in the US, which similar, like my fellowship director always told me when I was in the patient room, she's like, such a great job in the perfect spot. I always felt great. And then she'd come out and she'd be like, you kind of missed that one. But I think it's going to get there anyways, going back. So they will have to save all of their images so that if they get audited for the injection fee code, for the ultrasound code, it's there. So I think eventually, what I've seen in terms of interventions in the sports world, it kind of starts in the US 5 years before us, and then it eventually like trickles down into here. And neuroaxial blocks were like 10 or 15 years ago, they always had to save images. Now it's kind of come here. I think the same for joint injections and for tendon procedures. You're eventually going to have to save your images for them. The nice part of it is that like you don't have to upload, like at least for the US and for here, you don't have to like upload it to the system, to like an EPR system. You just have to like save the images on a disk. So like when I was in the US, we just had like big box of USBs, and like if the insurance company came, they're like, here are our images, you guys correlate them, which is nice. But I think eventually it will come that way.
All of our stuff would be saved anyway. Like we're in a hospital, we're very lucky. Like I think comes down sort of more from our biopsy work, where we always want to be able to prove that we were in the lesion if it ever comes to sort of was this representative of the tumor. And so it's sort of a good thing for our residents and fellows to do. Like a lot of the fluoroscopy, we'll take a fluoro store just to make sure that we're in the joint when we've given some iodinated contrast. And the same thing with ultrasound procedures as well. We'll try and save a couple of some of those nice pictures with the nice needle going in. We'll save a couple of those.
Yeah, those are nice because you guys have like the USB right in.
Yeah,
and like a tech put the name in the community. Like when I do it on my own in the clinic, like by the time I put the patient's name in and like save it properly, it takes a lot more time. So I think that it's going to go that way. But I mean, in my opinion, the fee schedule would then have to change too to reflect it.
You'll never save images when you're doing a presentation. That's the way that works.
Yeah, I mean, I got this like massive list of like when I was there, because we had to save all the images at the end of my fellowship. I just put like a USB in our each ultrasound system and saved them all. But now I have like 3,000 images, and I like none of like they're labeled, but I have to like go through them each one. So yeah, when I'm trying to find something, I can never get it.
Excellent. Thank you very, very much, guys. Really appreciate it. So guys,